share screen. And here, now you should see my screen, and we are going to start the presentation. There we go. So today we'll be talking about the pelvic floor issues after pregnancy, and just want to make sure that you can hear me okay, right? Good. And we did the introduction. So first of all, let me just let you know that I'm a urogynecologist. And what a urogynecologist is a sort of a short acronym for specialists in female pelvic medicine and reconstructive surgery. And a female pelvic medicine reconstructive surgeon, someone like me, does their OBGYN or urology residency, 4 or 5 years, and then they do 3 years of subspecialty training in dealing with just purely female pelvic issues. And then you have to take your examinations to become board certified. So if you have problems in this area, you probably want to seek a urogynecologist. We are going to go over resources available to you, go over pelvic floor anatomy, because it's a really complex issue, just what we do in terms of strategies to evaluate you. And then we are going to turn over to Lauren Trosh, who is our amazing physical therapist, who is going to talk about things. In terms of resources, when we talk about pelvic floor trauma, pelvic floor muscle injury, unfortunately, there are not that many dedicated sites to this issue alone. International Urogyne Association, American Urogyne Society, they do have some resources, but it's not specifically for this population. So a lot of time we do find our population literally searching out there on Facebook, on different social media, trying to find help. So the pelvic floor anatomy is very complex, and one of the things that I have to do all the time is explain to women who come to see me what has happened to them, and trying to teach them pelvic floor anatomy. And honestly, the pelvic floor anatomy is such that normally the providers that the patients have seen, they are not familiar with this anatomy either. So by the time the patients leave my office, they probably know more than most people out there. But what you want to imagine is that your pelvic floor is like a cone, and the opening of the cone is where everything needs to come through. The urethra, the vagina, the anus, they all are coming at the bottom of the cone, and the control of that cone at the bottom is accomplished by your muscles. And what holds the cone up are really your ligaments as well. So in terms of how long this cone-shaped structure, your anatomy, holds, it has to do with your genetics, right? So basically, when we look at somebody's pelvic floor strength and function, and we see that they're at their maximum in their 20s and 30s, based on the genetics that you have, you can see that patient A may go up to age 80 before they may have any decline in their pelvic floor function, versus the patient C, just based on their genetics, they would have decline in their pelvic floor function much earlier at age 50. So talking to the family is important to see whether your mother or sister has had these issues. And then the same patient that was destined to have deterioration at age 80, they can have issues that sort of knocks them off the course. So if they're living their life, and you can see here on one graph, they're at age 25 and they have an injury or issue with their pelvic floor, that may change their course, where instead of failing at age 70 or 80, the pelvic floor function will deteriorate much earlier. Then the other thing is that your lifestyle can impact when you deteriorate your pelvic floor function as well. So the same patient, again, that was supposed to have decline in their pelvic floor function at age 80, if they're working in a factory and they're chronically lifting tires or heavy lifting in the hospital or such, the pressure that they put on their pelvic floor is going to predispose them to earlier failure. Other things such as constipation, just bearing down constantly, would cause issues as well. So when we look at pelvic floor, we are looking at forces that are coming from above, putting pressure on the pelvic floor, and the pelvic floor that is trying to contract this and push it back upwards. So in terms of the pressure that the pelvic floor sustains, you can see that if you drop an apple in the pelvic floor, like the one that fell on Newton's head, that would be 1 Newton, right? But the fetal head, the baby's head just sitting on the pelvic floor doing nothing, creates about 16 newtons of force. So it would be as if you have a bag with 16 apples sitting on your pelvis, keeping pressure all the time. And the same thing when you are upright, and your posture can change the pressure. When the baby is coming through and you start getting the labor contractions, that force increases to 54 newtons. And just when you're pushing the baby out, the force that you're generating is 130 newtons of force going on the pelvic floor. So again, this would be similar to having a bag with 130 apples forcing pressure on the pelvic floor areas. And then the other thing that we need to talk about is the fact that all of this pressure that is coming on the pelvic floor has to come through the vagina, as a force that is going through the vaginal area and has to force itself through this area, a very small area for very large force. So we have done studies, and others have done studies trying to simulate this force that comes through the pelvic floor and the anatomy that I showed you. Now, the anatomy of the pelvic floor is such that you have different muscles going to different areas and performing different functions. And we are very interested in knowing that as the baby comes through, how are the muscles injured? And so there are two important things to remember. Number one is that if you get any muscles in your body, say the muscle in your arm, and you stretch it about 1.5 times its length, those muscles would rupture. So the skeletal muscles in your body are not designed to withstand more than 1.5 times of their length. So that's how much they can lengthen. The pelvic floor muscles, to let the baby's head come through, they have to lengthen 3 times their normal length. So somewhere between 2.5 to 3 times their normal length. So you can see physiologically, we are putting force on the pelvic floor muscles that are unrealistic for the muscles to sustain. So we know that the muscles have to stretch to unrealistic levels to get the baby through. But the other thing that we still have to learn and understand more is that the mother's muscles are designed in a way that they repair themselves really nicely. So we deal with two kinds of injuries: the injuries that are irreversible and the injuries that are reversible. So we know that the muscles stretch, and they may have injury, but they would heal themselves. So again, that goes back to your genetics in terms of why is that you would heal really nicely, but your neighbor who has a different type of genetics would not heal after delivery. So this is just a simulation of showing that if the baby's head came through, how the muscles stretch. And just remember that this is the, like where I'm drawing right here, this is the vaginal area right there, that ball the baby's head has to come through, and this area that I'm circling, that is the anus. So the pressure is all in this area. So as the baby's head comes through, you can see the muscles stretch more and more. And one thing that I have to mention is that the structures that you see here that are drawn, like for example, this line, this is the line that the bladder sits on. So if there is injury to this area, that would affect the bladder and some of the conditions that we are going to talk about later. And you can see this is the baby's head putting a lot of pressure on the perineum and the anal area, and it's about to be delivered. So one area that we always worry about as doctors is just this area on your perineal area. So the perineum is a highly underappreciated part of your body, where lots of different muscles come together that this simulation doesn't show. So in this area of your perineum, you have your levator ani muscles coming here. You have muscles from the labia coming together and joining. You have also muscles that we call superficial transverse perineae that come together. You have your anal sphincter muscles. So literally you have about 6 or 7 structures coming together to create the perineum. So for those of you who appreciate Eastern philosophy and chakras, this is the chakra that grounds you, and you can understand why, because it's just such a dense area of your body that brings all the structures together. So when we always worry about this injury to this area, and we have techniques that we employ at Inova to protect the perineum and the muscles as you're delivering your baby. So again, 2 areas we worry about. One of them is the insertion of the muscles to the pubic bone, and the other one is the perineal area that we try to protect as you deliver your baby. So when the injuries occur, we talked about the perineal body. There are various types of injuries that occur. One of them is, and we have different grading, where it's first degree, second degree, third and fourth degree. Really no kind of laceration is good. Then it has to heal. But then the third and fourth degree lacerations are particularly bad because they go to the anal sphincter muscle, and this has consequences in terms of the patient being able to control their bowel movements and as they heal in the future. What are the risk factors for this? Obviously, the first baby coming through, a baby that is more than 9 pounds. And once your cervix is totally dilated, that where you're at 10 centimeters of dilation, if you push more than 3 hours, then that can cause issues. When the baby's shoulder gets stuck, which is a very rare phenomenon, but it can happen. And also if there's an emergency where the physician is forced to use instrumented delivery to save the baby's life and the mother's life. So you're hearing these things, some of them for the very first times, anal sphincter injury, but you can have issues with inability to pee effectively, urinary retention, pain, tears that don't heal, leakage of stool or urine, and also pelvic organ prolapse. And some of you may be sitting here, what are all these terms? We have never heard of them. Or you're sitting here and you're saying, yeah, I delivered my baby and I am suffering from some of these conditions. So fortunately for you, we have a clinic that is totally dedicated to your type of condition. If you're suffering from this, it's geared towards postpartum patients. And Urinary retention is when there is edema, there is swelling in the vaginal area after delivery, and you just have so much swelling around the urethra, the tube that brings the urine out, where you cannot void. Sometimes also the patients may not be able to pee effectively because where you see these muscles where the levator ani muscles are, if there are tears in them, you may develop a hematoma or a blood clot that just grows and presses in this area and you just cannot pee effectively. That's why if this happens, we need to see you. Second thing that may happen, you may have painful intercourse for various reasons, even without injury to your levator ani muscles and your pelvic floor muscles. Having low estrogen and also breastfeeding thins your tissue so significantly that where your normal tissue is nice and thick in the vaginal area, and it thins significantly and undergoes atrophy just after childbirth, and when you breastfeed, this also will be thin. And we are not saying stop breastfeeding. We are saying just remember this can happen, and you probably need to use lubricants and be mindful of this. Painful intercourse also can come from muscle spasms, and as I told you earlier, you could have injury to some of these muscles that do heal, but say if there's injury to these muscles here, that injury can cause pain, and that pain may not go away, and muscles go into spasm as a response to the injury you have had, and then they don't relax. This can especially happen if you have muscle spasm and you attempt having intercourse too early, and then that just sort of stays with you, this muscle spasm. The other issues that are unpleasant that can happen is cystocele. As I said, the muscles that support your pelvic floor are supporting your bladder as well. So if there is injury to these muscles, your bladder can fall through the vaginal opening. So here you can see this is your uterus here, and the bladder should be above this line that I just drew here, but either because of the muscle injury or because the tissue that is under the bladder may literally tear and the bladder falls through it, it herniates, you can get a cystocele. The next thing that can happen would be a rectocele, and a similar fashion. Remember, there is a tissue that is separating your vagina from the rectum, and it's normally going this way and just separating the rectum from the vagina. But if there is a tear in it, then the rectum protrudes into the vagina and you get this rectocele. The same thing can also happen even if your tissues are intact, but there is muscle injury, and the rectocele develops. The other unpleasant thing that can happen is uterine prolapse. Uterine prolapse has to do with a few things. One of them being the muscles that we talked about. If these muscles that you see on this area are disrupted, obviously that cone-shaped structure that I told you is supporting your pelvic floor will be disrupted, and there will be more pressure coming down on that. The other thing that you need to remember is that you do have ligaments that are supporting your uterus. And those ligaments lengthen during labor as you're pushing the baby out. And if there is break in those ligaments, or if those ligaments are lengthened irreversibly, then you have prolapse of the uterus. So you can have prolapse of the bladder, you can have prolapse of the rectum, or you can prolapse of the uterus, or prolapse of everything. Another consequence of damage to the muscles, damage to the tissue, or a stretching of the muscles and the tissue irreversibly is leakage of urine. And the leakage of urine really occurs because, as you can see in this drawing, the cone-shaped structure that I drew for you uh, here is intact. And it's supporting your bladder, supporting your urethra that is holding the urine. And as that muscle um, uh, is either injured or lax, then you can see the cone-shaped structure, the opening of your cone becomes too wide to be able to hold the urine. And then with pressure, coughing, laughing, sneezing, you get stress urinary incontinence. As I said, we are very mindful of the perineum, which is the area between the vagina and the anus, because so many different structures and muscles come together. And when there is either a tear in this area or injury, that injury can extend to anal sphincter, and the anal sphincter injury can result in leakage of stool if it's not repaired. Now, one problem with the anal sphincter injury is that it's not the only thing that is keeping you continent. Generally, patients who have injury to their anal sphincter can stay continent by using their pelvic floor muscles. And they continue using their pelvic floor muscles. And by the time that they come to see us many years later, where the muscles have tired out, it would be too late for us to repair their anal sphincter. When you have muscle spasm, that can make bowel movements painful. And also remember, with just having painful bowel movements because of hemorrhoids or other pathology that is going in the anal canal, you can have a spasm of your pelvic floor muscles as a response to that. So they play on each other and they make life very difficult for our patients. So when patients come to us and see us at our clinic, one of the first things that we would do for our postpartum patients, if they suffer from any of those conditions that I mentioned, we do a very fancy ultrasound that is done with a non-invasive small probe. The probe is literally the size of my pinky. We put it inside the vagina, and it's not like the other kind of ultrasounds you have had in the past. We are not looking at your uterus and your ovaries. We are looking at your muscles. So this probe actually sits there very quietly, and then we push a button, and the crystals inside the probe turn 360 degrees, and they get images of your pelvic floor. It gives us, I'm going to show you some images of this and some 3D volumes of this for you to see what it looks like. But it looks at your bladder, urethra, and all the muscles, and it literally takes about 60 seconds to do and gives us a lot of information. So this is on my screen when I'm analyzing the data. This is what the data would look like, where we can look at the ultrasound images from many different points of view. But I'm going to show you some volumes of this, how these are. And here I have one open, and you should be seeing a 3D volume right now on your screen. If you don't see, Sue, let me know. But so this is a 3D volume of a patient that we obtained. And as we go in, I'm just going to go over it with you. So you can see right here, in the middle, that's the vagina. In the back, that's the anus. And as we go up, you can see the urethra as well. So basically here you have, that's the vagina, that's your urethra, and that's the anus right there. So, and then as we go forward, you can see your pubic bones right here. So that up here would be your belly, and back here would be your buttock. And this here would be your right side, and this would be your left side. So sort of anatomic view of things. So remember that, because I'm going to wipe all this out as we go in, and you need to remember that. I would not test you on anatomy after this. You may fail. So as we go in, we want to look at the muscles. We see the pubic symphysis or your pubic bone here. This is a very normal patient. And you can see here, again, this is her pubic bone. This is the area of the pubic symphysis. This is the urethra right here. And these are the, this is the vagina here, and this is the anus here. So giving you an anatomy lesson. So here, this structure here going around, this is your levator ani muscle, right? So this is your pelvic floor muscle looking from below. And then the other thing that I want to show you, that right here, going from side to side, what I just drew in pink, that's the tissue that separates the bladder from the vagina. And also when you look in the back here, the tissue here in green that I just drew, this is the tissue that separates your vagina from the rectum. So you can see if there is injury to your muscles, how this would impact the tissue that is holding the bladder or the rectum. So for example, if you have an injury to this muscle here, then your bladder will not have anything to be connected to, and also this the tissue over the rectum would suffer as well. So everything would be slanted and sort of goes this way if you have injury to those muscles. Yeah, fortunately, most women don't have this kind of injury that I just showed you. That's called an avulsion. Most women have small injuries in their muscles where they form hematomas from stretching. And so they have a stretching injury that does heal. But if you do have avulsion type injury, that happens to about maybe 12 to 13% of patients. And the problem with diagnosing those kind of muscle injury is that you just deliver the baby and you're sore all over, and it's really hard for you to know whether you have been injured or not. And that's why if there is anything abnormal, we need to see you and we just need to evaluate you. Unfortunately, this technology is not the kind of technology that is widely available. We have people coming from all over the world to learn this technology. And if other people around the country are using it, we have taught them how to do it as well. So I'm going to clear the drawing, but just going in further, you can see the anus here, urethra, and you can see the bladder on top there. So you can see the bladder and the rectum, but everything is very nice. You sort of look at it on the side, you can see that space. That's the vaginal canal here. I'm going to draw this here for you. So that's the vaginal canal. That's your bladder. And that's the urethra, the tube that brings the urine out. And these are your muscles. We're looking at them at the side. That's your anal sphincter here. And right here is your anus and the rectum, with the stool coming that way. So, okay, so you remember all of that anatomy, and we are going to go to the next one. So I'm going to close this now, and I'm going to open for you, just to bear with me as I open an ultrasound volume that is opening right now that shows you somebody with injury. Okay, so this is our 3D volume. You don't see anything. I'm going to lighten it a little. So this is an ultrasound of patient with injury, and right off the bat, if you look at this, even without really having trained eyes, you can see things are not really normal. They are not nice and organized like I showed you. So with this patient, you can see that her pubic bone is up here that I showed you. And so this is the pubic bone right there, and the urethra is here, but the anus is sort of to the side. So if I just drew a straight line here, the anus is supposed to be here, but hers is shifted this way. And just looking at it, you can see that not only she has injury to her muscles, but her injury is on both sides. So she has, the muscle is disconnected from her right side of the pubic bone, and her muscle is disconnected from the left side of pubic bone. So she has injury to both sides of the muscles, give her an abnormal anatomy, and she would be suffering. And this is what I described to you before. We are looking at her bladder. The other patient's bladder was nice, like a blob, sort of round circle up there. But with this patient, her bladder is literally falling into the vagina on these areas because she doesn't have any muscles here to support her bladder. And the same thing with the rectum, you see it's sort of shifting to the side as well. So I'm going to close this and just open another ultrasound, and then I would be almost done, and then I'm going to turn it over to Lauren, and we want to make sure we leave you some time for questions as well. So we are going to look at another volume. With this one, you can see again, seem like that the anus is in the middle where it's supposed to be. The pubic bone is there where it's supposed to be. And then so she has a more minute type injury. It's not a total injury like the last patient we showed you on her left side, which is your right side of the screen. The muscles seem to be intact, but she has injury on her right side. So if I go and draw that for you, so you see these muscles are injured here, but here she does have good muscles going to the pubic bone. So everything you can see, the anus is shifted this way, and the urethra is shifted this way as well. So they're all go through this side wall of muscle injury. And again, just going in further, you can see that even though she's injured, she has scarred this area to some degree and has healed. She doesn't have really her bladder falling in that area, but you can see again there is that defect on the right side of the vagina. So there is injury to the muscles, and her other structures, her ligaments are going to hold the load for her and try to support her. But this is a patient that will come to us many years later with failure because of this injury that she sustained earlier in life. So again, our clinic information, if you need our help or if you have friends or relatives that have these kind of problems. At this point, I'm going to advance the slides for Lauren, and Lauren is going to do the next presentation. Thank you.
Perfect. Well, thank you, Dr. Shobeiri. So I'm going to be talking about a lot of the same things or similar things that Dr. Shobeiri just talked about, but kind of zooming in, he covered people who had all types of injuries that, may or may not do well with physical therapy, but I'm going to focus on, those big bulk of patients who do well with physical therapy. Maybe that kind of falls into the category of people who had, different stress and stretch on their muscles during pregnancy and delivery that tend to heal and get better, and we can help them with that. So Dr. Shobeiri, if you can go to the next slide. So I'm very much going to overgeneralize the types of things that I see in pelvic floor physical therapy. And for those of you who don't know what pelvic floor physical therapy is, it's, the same thing as regular physical therapy, but we're focusing more on those tissues, those muscles, those pelvic floor muscles that Dr. Shobeiri showed you a couple times in a couple different ways. I also have like a little pelvic model if you want to see things in a more 3D way. all of this red tissue are the tissues of your pelvic floor that you can see. So just a little, we're not going to go over that too much since Dr. Shobeiri did a really excellent job of reviewing the anatomy. So Dr. Shobeiri also talked about the kind of spasming, overactive, painful pelvic floor. And he also talked about people who might have an underactive or weak pelvic floor. And you could see from all of his images, you know, all that stretch and stress those tissues might cause some injury and some weakness, but it might also cause, you know, some pain. And the ways that our muscles react to pain is by tightening up in a protective manner. And you might have someone who has some pelvic floor muscle weakness after pregnancy and delivery, and they also have some pain as well. So maybe they have a little bit of a mix of an underactive or weak pelvic floor, but also can have the overactive tight pelvic floor as well. So a little bit of a mix of that both. Some people have trouble kind of wrapping their brains around it. And I'll say, hey, you know, if I were to take my fist and hold it nice and tightly throughout the rest of the presentation, keeping the muscles of my hand really nice and active, that's not really going to make my hand a lot stronger. My hand's going to start getting white. It's going to start getting a little bit painful. And then when I try to use it or open it up and move to function normally, it's going to be painful and it might not function as well. So that kind of gives you a little bit of an analogy or a metaphor of how somebody might have overactive and underactive and muscle spasm or overactivity at the same time. So if you can go to the next slide. First, I'm going to talk about what we see oftentimes with people who have pelvic floor muscle weakness in response to pregnancy and delivery. This is an overgeneralization. You know, I'm going to talk about the same diagnoses that Dr. Shobeiri talked about, urinary leaking and prolapse. Sometimes those diagnoses can be associated with some spasm or overactivity as well, but I'm really going to oversimplify things. So if you can go to the next slide. So Dr. Shobeiri talked about this, the urinary incontinence, specifically stress or exertional incontinence, which is the involuntary loss of urine that can happen when you have an increase in intra-abdominal pressure. So these images, they're very oversimplified, but you can see on the left side of the screen, the abdominal wall, it kind of wraps all the way around. From your spine to the middle of your abdominal wall, and you can see how your pelvic floor would rest below your abdominal wall. At the top here would be your diaphragm, which is kind of right under the rib cage. It's one of your primary muscles for breathing. So if there is more pressure within the abdomen that the pelvic floor is able to meet, you might have some accidental loss of urine, which is why people leak with instances of increased intra-abdominal pressure, like laughing, sneezing, coughing, sometimes lifting or running. Next slide. Dr. Shobeiri covered this a lot. So with pelvic floor muscle weakness, now he also kind of talked about with both of these diagnoses that sometimes you can get urinary incontinence or pelvic floor organ prolapse because of issues or injuries to structures other than the pelvic floor muscles. But we're kind of just talking about, simplifying, talking about pelvic floor muscles here. When you have some weakness in those tissues or those muscles that support your pelvic organs, that can lead to some descent of those pelvic organs. And you can go to the next slide. And this is just a video, really simple. You can see how if there's more pressure above on those pelvic organs, the hammock is supposed to be a metaphor for those pelvic floor muscles. As there's more pressure from above, you can get some descent of those organs. The yellow organ represents the bladder, the pink one, the vagina, and the uterus, and the brown one, the rectum. So as you get more pressure from above, you might get some descent of those organs. So this is, Dr. Shobeiri and I are talking about a lot of the same things, but in different ways. So next slide. So I think this is what a lot of people want to know about If you are one of these people who are going to do well with pelvic floor physical therapy, with rehab to the muscles that support the pelvic organs, what is this treatment going to involve? So next. And everyone always is going to talk about Kegels. So this is just a visual representation of Kegels, or pelvic floor muscle contractions. So as this person squeezes their pelvic floor or contracts his pelvic floor muscle, you can see the closure of the anus, which I don't think that you guys can see my mouse. But you can see the pelvic floor muscles go around the anus. They also go around the vagina and the urethra as well. So you can see the closure of those orifices and also a lift to those structures as well. So this is just a nice representation of a pelvic floor muscle contraction, or Kegel, because a lot of people don't know exactly what it is, and a lot of people aren't quite sure how to do it, which is a big reason why people will come to pelvic floor physical therapy, just because they want to make sure they're doing the Kegel correctly and they're not just wasting their time. All right. So we can go to the next slide. So when it comes to doing, if you've got some weakness to those pelvic floor muscles that needs to be addressed in order to decrease your urinary incontinence or provide some more support to those pelvic organs, it's important that you're doing an intense exercise program, just like you would do for any other muscle that was weak or injured. So you need to stick with this program for at least 3 months, and you need to do your exercises 3 to 4 days a week, just like we would tell you to do for any other muscle that you're coming in for physical therapy. Now, the intensity is key. So the intensity of the exercise needs to be, difficult enough that you're getting changes in those muscles, that you're getting stronger. I'll tell people, if I want to get strong enough to lift a couch, me just lifting a 1 pound dumbbell, even if I did that 100 times a day, is never going to be enough for me to be able to lift a couch. So with those pelvic floor muscles, you get more bang for your buck, or the exercises are more difficult or challenging for those muscles in standing. So if you can do the Kegels in standing, that's always a good idea. You can do Kegels just by themselves, or you can do it in conjunction with other exercise like squats or other strengthening exercises that you're doing. And sometimes people will come to physical therapy just so they can figure out how to incorporate Kegels into the exercise programs that they're already doing. So next. And, usually people are like, oh, I don't want to just do Kegels. And that's good, because there's so much more that goes into these kind of issues like stress urinary incontinence, pelvic pain, or prolapse. Something else we might talk about is how can you manage your pressure within your system during activity. So we talked a lot about if there's more pressure kind of above the pelvic floor and above your organs, then the pelvic floor is able to meet, you might have leaking or symptoms of prolapse. So let's talk about something as simple as sneezing or coughing. If you're trying to do a really small kind of polite sneeze or cough, and you're kind of pushing all that pressure down instead of coughing or sneezing out, obviously cover your mouth. But if you're doing that kind of stuff and forcing pressure down instead of outwards, or with other activities, if you're breath holding, that might lead to an increase in symptoms like leaking or feelings of pelvic organ prolapse, which some really small changes can help with, because you're just helping to manage your pressure a little bit better. Dr. Shobeiri talked about constipation, how all that extra stress on the pelvic floor can be problematic. And that's something that we work on a lot in pelvic floor physical therapy for those people who need help with that, because a lot of the work that we do to manage constipation involves allowing the pelvic floor muscles to relax, and it involves coordination activities so you can more easily have bowel movements and put less strain on your pelvic floor. And also, we might talk about other things like how much water you're drinking, because all of that might have an influence on your symptoms as well. So next. Now that is a really brief summary about some things that you might see with an underactive pelvic floor. Now we're going to talk a little bit, because I know we want to get to questions about the overactive or tight, painful pelvic floor. So next. So people are always like, how do I know if my pelvic floor is weak or tight? Really what you need to do is get an exam so we can kind of check out those muscles. But some hints that you might have an overactive or tight pelvic floor might be that you're facing constipation, maybe pain with sitting, maybe painful sex, maybe changes in your urinary frequency, urgency, or some difficulty urinating or urinary hesitancy. You need to, for some of these things, you need to go to a doctor to make sure it's nothing kind of like those major medical issues that Dr. Shobeiri was talking about. But all of these might be a sign of an overactive pelvic floor. Next. So usually, just like if you came into physical therapy for any other tight or overactive muscle or pain, we want to work on decreasing any type of muscle tension or holding, like we talked about the kind of hand analogy, making sure you can get those tissues moving and nice and healthy, improve your coordination. We might work on stretching, exercises. We might do some soft tissue work to those pelvic floor muscles or muscles around the pelvis. We might also work on some postural things as well. These are just really general goals, but if you came to physical therapy, the kind of evaluation would look at all of the things that are going on with you, and we would design a specific program for you because everybody's problems are a little bit different. Next. So there are other considerations. Dr. Shobeiri talked about, the pelvic floor muscles as one piece in this a big puzzle, but hormones and other tissues and injuries all play a factor as well. So we oftentimes work as a team with our physician and behavioral health colleagues just to make sure we're getting you the best care that you can get. Next. So we talked before about pelvic floor muscle tightening. You can also stretch those muscles. As you can see, the kind of opening of the anus, the opening of the other tissues, the relaxing and dropping of those muscles. So the pelvic floor, like any other muscle, it's important that you're able to contract it, relax it, and stretching a bit. So that is just what some people will call a reverse Kegel, something that stretches and open up those muscles. And this kind of motion is really important for bowel movement. So that might be something we need to retrain. But just wanted to give you guys a little video of this. And then we'll go to the next slide and we'll just kind of wrap up. These are all just different ways you might be able to stretch your pelvic floor. We can just breeze through these. It's just an example of some treatments people might have, just different stretches. You'll see some of these look a lot like yoga moves, all of these things that kind of open up the pelvic floor. But there's a ton of ways to treat the pelvic floor. This is like a little handout I'll give patients to help educate them on how to do a little bit of massage to their pelvic floor muscles. Next slide. There's all different tools and devices and things that might be able to help you with painful sex, but we don't have the time to go into that, so we'll just keep on going. And of course, we talked about constipation, so working on posture and different things that might be able to help you have a bowel movement is really important if you're having any type of pelvic floor problems. So I think that about wraps it up. I don't think I have any more slides.